All right. I want to respect everybody's time, so we're going to go ahead and get started. I'm sure there'll be more coming in, but thank you for everybody coming today. We are excited to present on some information on what should be looked for when preparing your practice for a transition. This information will be useful for both those looking to sell as well as those preparing to buy. Before starting, I wanted to thank our sponsor for this event, Caber Hill. Businesses all across the country are being pursued and directly solicited by large and intensely competitive buyers. These groups invest immense resources that give them an edge. It's how they maintain an information asymmetry. With Caber Hill advisors on your side, they level the playing field. No fire drills during the due diligence process, no surprises at close, just peace of mind for what matters most. As a reminder for everyone, this event will provide 1 hour of CE. We are at Smart Training are a PACE provider, and so a certificate will be generated and sent out to those that are in attendance for the full length in just a day or two after the event. With all the housekeeping items taken care of, it's now my pleasure to introduce my good friend David Wornica. David is the Director of Healthcare Compliance at Smart Training, holding certifications as a CDIPC and a DISIPC from the Association of Dental Safety, formerly known as OSAP. Before joining Smart Training, David worked as a registered dental assistant in Austin, Texas for 2 years for two of Smart Training's clients. That's how we found him and recruited him, where he served as an OSHA lead and infection control coordinator. He continues to maintain an active RDA license. At Smart Training, David has conducted what he reportedly feels as 1 billion compliance inspections for dental practices, collaborating with practice owners to address and remediate issues identified during the inspection process. If you've met David for even 5 minutes, you can tell he's passionate about it. In his free time, David, along with his wife, Christine, enjoy floriculture and beekeeping on their acreage in West Texas. He would like to apologize in advance for any allergies that may be affecting his voice during the webinar. Hopefully it holds up throughout, though. And with that, I'll turn the time over to David.
Hello, everyone. Joshua, thank you for the warm introduction. I wanted to use the word convivial today, so I'm going to say the warm and convivial introduction. Very excited to be with everyone today. Just kind of dive right in here. Let me jump past that. So I am the Director of Healthcare Compliance with Smart Training. We're a learning management software and OSHA and HIPAA compliance company. There aren't really any other disclosures beyond that. So the objectives for today, we are going to identify OSHA and HIPAA compliance concerns that may potentially stall a transition. We're going to share the things that sellers can do, determine how to secure a higher sell price, and just kind of a whole smoother process and the evaluation process as well. And we're also going to work on sharing information how buyers can gain confidence, learning how the practices get benchmarked against others from a compliance point of view. Definitely excited for this information. It can be a dry topic at times, but it's definitely something that we need to consider in these transactions, which is why we're going to share this information today. So I want to give you a little bit of an understanding on OSHA and HIPAA in sort of a general sense. I mean, we all know a little bit about OSHA and HIPAA, but a lot of times we don't know what we don't know, or there are little details we might be unsure of that can cause major issues if they're left unaddressed. We've all heard those horror stories and different things, from practices getting citations, getting notified, or heaven forbid an inspector or industrial hygienist or someone showing up. Naturally, taking all these things into account is going to add many layers of complication to any kind of transaction. But hopefully today we'll be able to clear some of that up and share some of the more involved items that do occur. And, because we thrive on the complex and we love additional layers of complication, I would share that OSHA breaks apart a little bit further um, depending on the state where we're practicing. As many of you know, that different states have their own OSHA programs. I'm going to share this little map with you. And, if it's your first time seeing this and maybe being aware that about half the states do have their own state program and the other half are federal, there are some little hybrid states that do have their own state OSHA programs, but it's local government workers in particular. It's not really private practices and things like that. But we're going to focus on state and federal today. Obviously, all the ones in the blue here have state plans, and green is federal. I would assume we probably have some folks from all over, so I think this will be beneficial to everyone here. Predictability is kind of a loaded word, but I would say that a lot of the state and federal plan are fairly predictable in nature. They're going to have a lot of similarities. There are some exclusions, of course, and I would encourage anyone, if you're in a state with a state OSHA plan and you have questions or any questions in general about the presentation, please go ahead. My contact information will be at the end. I'm happy to provide additional info. But it's just important to recognize as well, by looking at this map, dentistry is considered general industry so far as OSHA is concerned, which means it's more than just infection control and bloodborne pathogen standards. A lot of times folks kind of, you don't think about all the other employee safety items that aren't directly related to dentistry. So we'll cover a little bit of that coming up as well. So let's talk a little bit about determining benchmarks. We'd mentioned that in the objectives in the opening. So what does it look like? How do we make a determination? Depending on where we practice, we know that apples and apples comparisons could be difficult, but it's still possible. We can move the crux of the objectives we'd laid out a moment ago, and that's what the data we're gathering. How do we do this? How do we go about and quantify making all this information actionable? Well, definitely, a thing that we always want to focus on is not only just gathering the information, but gathering it in a way that we understand how to move forward with it. Oftentimes, we may hear different things from different folks and say, "Gosh, how am I supposed to apply that in my practice? How am I supposed to do that?" Well, when conducting an inspection, it's very important that we have everything discrete and with key stakeholders. Basically, we want to make sure that we're not broadcasting to the world, "Hey, we're going to be having an inspection, we're undergoing a transition, and there could be some issues that affect the employees and business associates and whatnot." So one key to conducting an inspection is to keep everything discrete. Another item, as far as the inspection is concerned, is our report and expert insight. If you're going to be having an inspection, ideally we have someone that goes ahead and gathers up all the information that's going to be necessary, and this information is going to be very detailed, and it can dive into the weeds. We can start getting into the CDC's MMWR. We can start diving into bloodborne pathogens, hazard communication standard, and it can get complex pretty fast. So it's very important to have expert insight on that, to distill the information and kind of break it down into something that's actionable. More often than not, if you should have a industrial hygienist or someone come in and provide a inspection report on items that need remediation, or if there's already something like that going on in your practice and you've seen those documents, you definitely understand that it can be a little complicated reading through or kind of distilling that information to something actionable. So kind of getting ahead of the game and making sure that prior to any kind of transaction, there is an inspection from a disinterested third party, I would say, that they're providing you info that you can act on. It's not something you have to decode. And then we want to talk a little bit when conducting inspection about benchmarks and your remediation instructions, which I kind of alluded to a moment ago. But it's very important to benchmark the practice in our eyes. We want to know exactly how to classify what's going on at the practice. Are we in a practice that is maybe struggling with our compliance, or are we in a practice that's just kind of holding their own, towing the line, doing what they're aware of, maybe missing a handful of things, but trying their best, or are we in exceptional practice that has been, well ahead of the curve, having all of their, ducks in a row, as it were, And those ducks can get a little out of control at times, which can certainly be an issue. This little graph here, talking about what our data shows, is when we have inspections, we do divide up into these, various. It's a good way to say this. I guess various levels. And as I'd mentioned, we have troubled practices, struggling practices. You can see the list here: average, solid, and premier. These are the numbers out of about 100 inspections that we'd put together. And on average, as the numbers would bear out, we see many average to struggling practices. And we're going to take a look in a little bit at a couple of different scenarios that kind of dive into what that looks like to be struggling, what that looks like to be average. Obviously troubled is a whole other concern, but we'll get into that too. But oftentimes, these are the things that folks just don't realize that they need to do, or maybe they're not applying the knowledge that they had gotten at a course or out in the field or something. That's often how folks find themselves in those positions. And it's not a huge struggle to come back from that. So, I would add that it's just important not to be demoralized if you're like, oh my goodness, we have so much stuff to do. You know what? You have a team in place, you have confidence, you're gathering the information. So really it's the best place to start. I would mention too, I should note the average OSHA penalty, and this is not to be frightening or anything like that. In 2024, based off of what we've seen in violations by establishment, state and federal, the average violation somewhere between 2,500 and 6,250 per violation. The higher numbers, obviously, with a serious violation. If the violation is considered willful, in other words, you knew about it, did not remediate it, and just kind of let it fester, that can go up by a multiplier of, I want to say 10, if I'm not mistaken. So obviously, if you know about things that are issues, you want to get them remediated as soon as possible.
Quick note there, David, it's not
please.
Possible 10x, it's a mandatory 10x increase if it's a willful.
Oh my. So nobody wants that. So a mandatory 10x on there. Wow. All right. Let's take a quick peek into scenarios here. Now, I've got a couple different ones that I just wanted to share today, as to not just kind of, a lot of the stuff sort of runs together, so there's no need to go through every single one. But scenario one, I would call this as it says here, newly inspected practice. They don't have a compliance program in place. What that means is maybe they've attended seminar training, whether it's at an all-day CE event, perhaps a conference. Maybe you've closed down the office and sent the team, that kind of thing. Or perhaps you had someone come in from, a group, a vendor, whomever, to come in and train and evaluate the practice. And one of the quotes that I hear often when we kind of talk about inspections and talk about how we're going to approach these things with practices is, oh, we're good. We've already had our OSHA training this year. In fact, we're certified. Which can certification, yes, that not something that you get when you complete training. You are not certified. You're just completed sort of a checkbox for the year. What I would strongly encourage folks to keep in mind too, and I've been sharing this a lot recently, is your responsibilities begin where the training ends. Just from talking with so many folks recently. And I'm kind of jumping out here on a little climb up on a soapbox, I suppose. What we're finding is folks are taking their training and they're checking off that box, that perceived checkoff box, and we're not taking the knowledge that we gathered from training and bringing it into reality. And that can be something as simple as your bloodborne pathogens training that you have. Are you getting the documentation for hepatitis B vaccination for your team members? Do you have that documented? Are you doing that at the employer's expense, not the employee's expense? And when I say that, that means not charging the employee's insurance and then paying them back. Technically that's the employee's expense at that point. So just little things like that we need to keep in mind. And that's just one of a long laundry list of things we've seen or encountered. So talk a little bit about newly inspected practice. Your average score, what we see on our compliance inspection sheets, are about 55 to 65%. And generally, that's a lack of records is something that is always a concern. And these aren't just training records. These are records on our infection control. These are records on some general industry items, like fire extinguishers. Are we checking those monthly? Are we documenting that? Do we have an annual tag from an inspector on all our units? Are our units mounted? That's yet another concern. That's actually considered a serious violation if your fire extinguisher is not mounted. Just all these things that you find in these practices. Oftentimes, once again, these are things that folks just simply aren't aware of. No one ever mentioned that to me before, or I'd wondered why that tag on my fire extinguisher said 2021. I just figured that was when it was installed. It's things like that. Other issues we bump into with practices in this type of scenario is their binders. So often we see the templated binders that are purchased, and they look really slick. They're really nice, and they're in pristine condition. They've been unboxed and admired, and then put up in a cabinet, and no one's touched it. So that's kind of an issue. A lot of folks will have these templated binders and not realize you need to fill out the information within, and you need to share that with your teams, and you need to be putting this somewhere where everybody has access to it. And all of these things need to be updated annually, or else again, we start talking about serious violations. And we know that if we know about that, it could very well turn into something that's willful. And these binders, what we're talking about are your written programs, your emergency action plan, exposure control, hazard communication, respiratory protection, if that's active not only in your state or if there's a federal guideline. So these are all things we have to keep in mind. Those are your safety programs. Another item I might mention, and I hope you all, if you're not doing this, maybe I'm sure you have a notepad. You'll want to be checking your eye wash stations as well. Your eye wash stations need to be checked once a week, and what we're checking for is that the flow rate is appropriate. The caps will pop off the eye wash station when it's activated. It should be easy to activate too. Everyone should know where that little rascal is and how to activate it. And we want to make sure that there's not scalding water coming out of there. Those are the things that you're checking weekly, and you should have a log for that. You should have documentation. If you're ever not sure, keep documentation. It never hurts. Just an initial date pass. Never hurts. Some people will keep that in a binder. Some folks will even print out a log and keep it on the inside of a cabinet. I don't think I've ever seen anyone get fined or assessed a violation if they have some sort of documentation in one of those two ways. So just keep that in mind. That's just another little nugget of things that's maybe not in our top 10 of issues, but it's up there and could certainly get you in trouble. I mean, worst case scenario, someone gets something in their eye and it's not working, or maybe you don't have one. That's certainly an issue. And I should mention, and again, this is kind of not off topic. We're talking about eye wash stations. It's not off topic, but those little bottles that you have, those little flushing bottles, that doesn't constitute an eye wash station. It's good to have, and it would work in the process of getting someone from, maybe a remote area in the practice to the eye wash station, but those don't suffice for an eye wash. And I believe it's because they don't have the capacity of 15 minutes of flushing. I think you'd probably get 3 or 4 out of that. Anyhow, and some non-compliant infection control procedures. Oftentimes, these newer practices that are being inspected are kind of missing the boat on a lot of different infection control items, one of them being dental unit water lines. We know that those need to be tested quarterly, but they should be tested monthly until you get consistent passing results. So that's yet another issue that a lot of times people just kind of overlook. And these are all things that could, cause some serious issues, not only to your patients and your team, but if we're in the middle of a transaction and you find out like, oh gosh, this practice isn't really practicing infection control. I mean, maybe they're paying it lip service, but there's no documentation here. I don't know if any of this is happening. that could be an issue. And it's definitely something that, a buyer and a seller would be concerned with. If these things aren't going on at your practice, gosh, they really need to. And then the last item, without hanging on this slide for too long and burning it too far into your to your retinas, is a drive-by bloodborne pathogens program. Like I had mentioned earlier with the hepatitis B documentation and employers' responsibilities, there's so many things and so many questions and so many emails that come in about bloodborne pathogens and how exactly are we compliant with this? What do I have to do? I would strongly encourage everyone, and it's not a long read, but it's not an exciting one, is to actually go to the Department of Labor website and look at the bloodborne pathogen standard. It's a quick read. I mean, you'll want a cup or two of coffee, but it's definitely good information. It's actionable information, and it's quite simple to put into practice. In your practice, and there's really with the accessibility of the information, there's really just no reason not to have that done. So let's see. So as far as your timeline to remediate all these things, obviously, right now after we end this webinar is a great time to to go ahead and get these things sorted out, or at least begin sorting out some of the things we've been talking about. But after you receive an inspection report, it's pretty much go time. Generally, you're going to find there's a lot of items that can be completed pretty easily, and generally there's some things that need to go on order. A lot of times that's, hey, I don't have the right eye wash station, or oh my goodness, I need to call someone and get them in here to look at these fire extinguishers. So there are some things that you can make a quick phone call and that gets going, or maybe put an order and maybe in a few days that comes in. So there's really no excuse not to be able to get these things at least active, and at least show kind of a good faith effort that we're working on all of this. I would say general rule of thumb when we have one of these scenarios, about 1 to 6 months and that's quite the time span, but 1 to 6 months is pretty accurate, because like I said, we can get through the easy stuff and then work on the more difficult things, and just try and get through it. I would encourage anyone who's looking at any kind of inspection report to say, okay, so OSHA, employee safety, what on here is like detrimental to employee safety? And I know I keep saying eye washes. Yes, make sure you have your eye washes. Make sure you have Hep B vaccination, for everyone on the team. Those are the things that you generally see on violations by establishment. Also chemicals labeled, and it's just a lot of things that you would say, gosh, I never really thought about that, but yeah, that could be a serious issue. So yeah, 1 to 6 months for your timeline to remediate in this scenario. And as far as lingering issues or struggles, I would say that a lot of times people struggle with new team members when they come on. A lot of it depends on, what kind of culture we have in the office for our new hires. A lot of times do we just sort of grab folks and say, all right, you've got your license, or you've got your training, or, whatever to get into this position, and we love you and we can't wait for you to see patients, but we don't have any documentation of all that. So that's something that definitely affects a lot of practices in this kind of scenario. So I would harp or continue to harp on documentation for all things. I know that's almost kind of a vague term, but I can definitely provide you a list at me in email at the end of the presentation, or we have a Q&A session so we can spend more time on that. So where do we go from here? So if we're going to achieve success in this scenario, we've got to embrace the data and champion the changes. So that's and that's kind of like a platitude, I guess, but that's kind of what it takes, though. I mean, we have to get the information and we have to say, okay, what am I going to do with this? I have actionable info, and there's no reason that I can't start on this. So the most successful folks find a champion in the office, whether it's doctor, practice owner, could be your lead clinician. Maybe you've got a great front office manager who you're like, gosh, they could take this on and shouldn't be a problem. But just begin championing. Begin working through the program. It's you're never going to be in such a difficult situation that you can't say, you know what, let me just kind of hand some of this stuff out. We'll start working through it. Then we'll have like a quick meeting, or our morning huddle will cover it. So never a poor thing to do is just get the ball rolling. I feel like so many times people just pop the ball and they sit there looking at it and say, why isn't it rolling? It's like, you popped the thing. What are you doing? Take the information, do something with it. So all right. So that practice on
David?
oh, go ahead. Sorry.
Just one, I want to pile on there just a little bit. I want
Please.
to say that what we've seen time and time again is whatever the doctor asks about or focuses on gets done. So absolutely, if you have a front office staff that can take it, or lead assistant or whoever that's going to be the go-to person, that's great. However, the doctor is really where things start. And if they're not asking anything about where are we with these 3 things that were identified that we need to resolve, then it typically doesn't get done. So I just wanted to say that.
No, that's very important information. It all has to start somewhere, and it all has to be followed up on too. I mean, these things don't exist in a vacuum. We need to make sure that, there's continuous action here. And I would encourage as well, constant communication between the doctor, the team, and also whomever did your inspection, because you're going to have questions. You're going to need clarification on items. You may even need additional support, like, hey, I could use some spreadsheets to document this stuff, or can you give me a list? So really excellent information. Thank you, Josh, for jumping in there. So in this scenario, as we'd mentioned, the typical person coming in is going to have probably about 31, 32 different items that need remediation, as we call non-compliant items. And again, not trying to scare you with the number beside there, but it's a large number. It's a lot of liability. And fortunately, it's very easy to knock that number in half. And so much of that is just taking action. That's going to be kind of the continuing theme here is taking action. And it's not hard to move up to average and to solid as long as we're moving forward. So important. Yeah. Let me see what we've got on our next scenario here. Scenario 2. Now, this is a little bit different, but some of the information is about the same. So I want you to listen to the differences here. This is going to be a newly inspected, established practice. They have an OSHA and HIPAA program in place. Okay, they've probably had in-person training and a site evaluation by, an industry expert. And oftentimes we hear, well, they gave us a binder. They walked around the practice. They spent a lot of time with my team, quote, with my team. They covered infection control and patient care. Okay, that's good. And we signed stuff and got certificates that say OSHA training 2024. So this is what I would call this scenario is kind of your checkbox practice, kind of your practice that might say, okay, we have the binder, we've gone through, we've looked at it, it's up in our cabinet, folks know where it is, I have the certificates, they're tucked in the sleeve of the binder. Someone comes in, just show them the binder, we're good to go. Someone walked around the practice. So they should have done whatever they did, and maybe they showed us how to use a few different things or how to do a few different things. So that's good. You're probably going to have a lot less items to be concerned with on the final inspection report, and that's good because now we know we're not in that scenario where we probably have 30 some odd items. There are quite a few folks that come to us that are in this scenario, and you can understand that a lot of times, we're going to see the same sort of issues overlapping on these various groups until we get to, say, a scenario where the office has, maybe been inspected a couple of times, or maybe they've, really championed the process and come together, coalesced as a team to work through everything. So our average scores here, on the low side, you may see them in the 60s, but that's not the most common. I wish I'd maybe put 70 on there, but so roughly up to about 80%, which means you've probably still got, 15, 20 or so items that are non-compliant. These will have incomplete training records. Generally, what we see is the practice had some new team members come on, and maybe they never acquired those records. And truth be told, more often than not, if there is a violation, or let's say there's a complaint and the office is contacted, I'm going to share with you pretty much how it goes down. Maybe you had a new team member join the practice. Everyone's excited. Team members excited, doc's excited. They're in a treatment area and they get poked. They say, "Oh my gosh, I'm poked. This is bad." And maybe the practice didn't handle it the way that new team member. Maybe they didn't have like the trust built up, or maybe they hadn't, documented the Hep B status or that kind of thing. Team member maybe says, "Gosh, I'm going to file an anonymous complaint. I'm just not comfortable how this was addressed." Anonymous complaint goes out, either an inspection or kind of a documentation gathering occurs, or you need to submit different items to your area office, and you're missing that documentation. Maybe they haven't had that Hep B vaccination documented. Maybe bloodborne pathogens training hasn't been completed because we were just a rush to get them in and get them working. Maybe we were shorthanded, and that's where things can start stacking up. And if an investigation does occur at that point, which is fairly common if they're looking at that many things, then we start talking about, are the written programs up to date? Is there an exposure control plan, like a program? Is that up to date? Are we following it? Is it just words in a binder? Is it just, things we heard in training? Or did we, put our arms around that and pull it out of the training and start applying it in real life? And based on the information from the inspector, it sounds like in that instance, the practice maybe didn't do that. So that's another issue that we find ourselves in these issues, in these situations or scenarios. Also missing testing, maintenance documentation, as it says. That's something that we see all the time. You may have records, 2-3 years worth of records, and then there's like a 6 or an 8 month gap or even a year gap. So what happened here? Oh, so-and-so went to hygiene school, but she's back now. It's like, well, or he's back now. It's, oh, well, you got 8 months of missing data here. Like it didn't get handed off. Like where's the culture here? Where's our infection control culture? Where's our safety culture? So that's something we see in these practices, that are established, and they're trying their best to do everything right, but little things slip here and there. That's something we see, and that's something we try to bring into the forefront in these inspection reports and in this information, and applying it in the real world. I cannot stress that enough. So often people get this great information at courses and great information. They take wonderful notes. And then the page gets flipped on the notes, and we start taking notes. Okay, I gotta pick up the kids. And then we just kind of lose track of everything. So very important. And again, I can't stress the general industry items enough as well. Those fire extinguishers, those eye washes, those exit signs, just all the things that we kind of take for granted. Being in dentistry, we're so focused on bloodborne pathogens and infection control that sometimes we let the other little safety items in the practice slip. And we see that often, and that's usually what an established practice with an existing program undergoes. It's things like that. So time frame, time frame to remediate. Well, it does vary. I wouldn't say that we're looking at 1 to 6 months. Generally, we're going to be about 1 to 2 months, because it's really, at this point, a matter of just kind of tightening things up, saying, okay, now our plan is we're going to do this. This is assigned to this person. You're the backup. If we have changes in staff, this is our protocol. We pull out those written training programs and we go ahead and make the adjustments we need to adjust. Maybe instead of having our spreadsheets on the inside of cabinets where people forget about them, maybe every Friday we have on the schedule just a little block out for 20 minutes for one particular team member who's assigned to go around and check everything. Make sure we have our eye wash document, fire extinguishers document. Did we do our spore testing? How about our water lines? Did we test that? So something like that. Always keep that in mind, especially if we're looking and we're talking transitions. How cool would that be to say, yeah, my OSHA game is tight and right. Like, here's our documentation of all of our, all of our maintenance and testing. Here's all our training records. And yeah, we've got everything we need. We have updated written programs. Everything is good until it expires in December 16th. Like, how cool is that? That would make you feel really good about that practice. Say, wow, they're in the game. They're doing what they need to do. Plus, you can say, yeah, look at these inspection reports. This is where we were, and look how far we've come because we're dedicated. This is safety. This is safety culture we've established in this practice. So, I would say 1 to 2 months is probably a reasonable expectation in that, because you've pretty much got what you need. You just need to tighten it up. Struggles in these scenarios. Really, to be entirely honest, it's sorting through what you have and trying to see what's missing, because you're going to already have a lot of data and a lot of things kind of kicking around. So sometimes I find a lot of people just kind of do like sort of a reset and a fresh start at that point. Like, they may say, okay, I have cobbled together 2 or 3 different systems. I'm going to go ahead and just put all this under one roof. I'm going to put it all in one, just to simplify even further, in one spot. Everyone knows where it is. Everyone knows it's the red binder. Everyone knows it's the black binder for testing. Just simplification, gathering your data, cleaning it all up. And after you do that, I mean, gosh, it's kind of cruise control at that. Just make sure you're doing everything, updating when you need to. But a lot of folks kind of get stuck at this spot too. I'm going to jump to my where do we go? I'm going to jump to my next one. A lot of people kind of get stuck in that average to solid practice. And I'm going to spend just a second here talking about why that happens. A lot of times, and we're all guilty of it. I know when I was practicing, I was guilty of it too. You fall into your own routines and you fall into your own, we've always done it that way, or that's just kind of how we roll here. That's what we do. And, no one's ever told me that's not the right way to do it. So, okay. But some of these issues, and we see it on inspection reports all the time. I'll just jump in and give an example is, hey, how do you bring your burrs to the operatory? Do you put them are they in a burr block? Has that been sterilized in like a sterilization pouch, right? Do you have everything you need in the procedure, or are you kind of reaching behind you or in that little drawer for that clandestine box of burrs with your cotton pliers, and you're like, I need another 330 or a KS1 because this crown just won't come off, and you grab that out of that box. That burr is not sterile. Maybe clean, but it's not sterile. So then we're using a critical instrument, which a burr is considered, that's not sterile on a patient, right? That's something we see on our reports all the time. And there are tons of different ways to solve that issue. Maybe have your assistant or whomever's running your sterilization, maybe put in a couple extra KS1s or KSOs or whatever you're using, or, maybe have keep in mind at the beginning of procedure, we're gonna throw some of those into the not the autoclave. My brain is escaping me. The Statum. Maybe we're going to throw a few in there so they'll be ready to go in 20 minutes, or when Doc does the hygiene check, just in case, so we can pull them out and bring them over sterile. It's little things like that would have to change from what we're used to doing or what we often do that ends up leading to folks kind of maintaining it solid or average and not really moving upward. So that's just one of the things that we see, and one of the things we would put on the report and encourage folks to do. Josh, did you unmute?
Yeah. Question here is,
please,
what kind of compliance score, we're looking at these, what kind of compliance score would be appropriate to aim for when you're looking to sell or when you're trying to purchase? Is there a minimum that you would suggest people have from this?
I would say if you've had an inspection and you're like serious and you're saying, I'm going to take this information and I am trying to improve go for an 85 at the start. Does not take a ton of preemption. You can pretty much just say, okay, I'm going to look at my training. I'm going to look at my written programs. I'm going to make sure those things are up to date and make sure they're active. I'm going to check my eye wash. I'm going to check my this. That's kind of the best way to come into that, because you're going to come in at a higher score and you're going to have less to deal with afterwards. And honestly, you can find a lot of that information just by looking at violations by establishment on the OSHA website. You're going to learn what's out there and what the issues are and how to correct them pretty quickly. And there'll be some incentive seeing those fines on there as well. But yeah, I would say try and come in at an 85. It's not terribly difficult to achieve. Mm-hmm.
Now, would that be enough to really set them apart and kind of make them stand out when they've got prospective buyers looking?
Yeah, I would say definitely 9 times out of 10, if you're coming in there with B plus average, you're looking really good, because they know if you're looking into the obscure little items in OSHA, like, okay, oh my goodness, these folks are paying attention. Like their attention to detail extends beyond the mouth, beyond what they're working on a day-to-day basis to be wrapping these items. So yeah, if someone can come in around 85, 90%, that's just a beautiful thing. And we talked earlier about the time constraint to doing that. Once you have the information, I mean, ball's in your court. You can change these things in as quickly as a month of just getting after it, making assignments and following up. So yeah. That's a good question. Any other questions came in while I was carrying on about the...
No other questions at this point. So I appreciate you taking a quick break.
Oh, not a problem at all. And please, everyone, if you do have questions, don't hesitate to submit them. I'm happy to, like what Josh and I just did, just to pop back in, because this is all about you and all about providing the knowledge that is going to help you. So evaluating benchmarks, and this kind of brings us to it's a perfect transition into what we were just talking about. Generally, the struggling practices or the timeline to correct. This is really good information here, and I want y'all to just kind of take this and really just think about how it would apply to your practice. If someone handed you a report that did have a hefty amount of what we're calling violations on here, non-compliant items, are we going to realistically be able to gather this information, to take the information from this report and act on it? How can we get ourselves up to that next level, that next benchmark, and look even better to buyers or as a seller to a buyer? How would we go about achieving this? And to be completely honest, as I'd mentioned, the power is in your hands. If you want to get 100%, you can get 100%. There's no one stopping you from that. It's just a matter of saying, I'm going to change maybe the way we do this part. We're going to get buy-in on the team, and we're going to go ahead and just go forward on this. I mean, one of the things that you bump into, obviously, is there are cave people out there. Those are the folks, and I love this term, cave people, consistently against virtually everything. Like, you're going to have those folks that are like, darn it, I'm not changing how I'm going to do that with my birds. That's just ridiculous. They come sealed in a package. They're fine. No, they're not. If they don't stay sterile, they're not sterile. So, I mean, you're gonna have folks that you will get a little pushback, and it's strange because you're talking employee safety, but you're gonna have employees giving you pushback, which is always kind of odd. It's sort of a little catch-22 there. But there's no reason that you can't get up to 100%, especially if you have resources in place, and especially if you can get in touch with that person who inspected your practice, who gave you the information, and is actively working to give you the tools for remediation. There's just no reason it can't be solved. So ask yourself some questions. Now, how do you know when you get there? So what's your comfort level with what's going on in your practice right now? What's your comfort level with that? And with everything else going on, what's realistic? How do I go about taking this information and bringing it into real life? It's realistic. And since there's no grace period, where do you start? So I think we covered a few good pieces of information there. And to dive a little bit further, I want to just throw some qualifiers in here. So statements to supply a buyer. This is what folks are going to want to hear, and this is what you really want to be able to provide. We have training records for the last several years. That's existing employees, that's new employees, and that's even folks who have moved on. Do you have those records? Your OSHA binder and written safety programs, those are updated annually. And they're not just in a templated binder, they are customized to my facility. And if there are any changes that happen in my facility, those are updated in there. And that's as simple as, hey, my front office manager, she's out on leave for the next 6 months. Who's taking roll call if we have to evacuate the building? If you have to evacuate the building, obviously someone's going to want to see what's in your written safety programs because obviously there was an incident. And if all your information's out of date, that's kind of a problem, even if it's stamped on the outside that it's good through 2024. So make sure, and you can honestly say this to someone. Our OSHA binder written programs, they're updated annually. They're completely updated. And we've never had an inspection in this facility. We've never had an industrial hygienist here or someone from OSHA pop in, but we're ready. We've had third-party inspections, and we've gathered a lot of great information and used that to remediate any issues. So you're confident when you're saying these things to folks. And to go on a little further, we have business associate agreements available. We've conducted annual HIPAA risk assessments. Like, we're protecting our patients' PHI. You're not going to have any our next one. We conduct our HR operations professionally and ethically. There exists no potential landmines. And when I say landmines, I mean, we're talking about like, oh my goodness, this person left 4 months ago and man, they were breathing fire when they left. It was a bad situation. Like, do you have any of that stuff hanging up there? that's going to come back and bite the facility. So yeah, those are, and I know we didn't talk much about HR operations, but if you're CEFF certified, or you're running an ethical operation, number 5 is just going to be a simple one, But I'd say if you're just churning through help and maybe those turnovers aren't going well, might be time to do a little inward looking and kind of see about that. So if you can look at these 5 items, and I'll jump back one screen just for those that might not have saw those others. This is key information. These 5 items, these what I call them qualifiers. These are things that as a seller you want to be able to tell that buyer. And those are coincidentally kind of your top 5 issues for that. So I'm going to jump down, and we've already seen this little slide. I'm going to leave it there for a second. Then we're going to jump on to the things that the buyer should be looking for, and they're going to be fairly similar here. Okay, questions to ask your seller: do you have training records? Have folks been trained? Most of those folks, if not all of them, are probably going to be part of this new practice after the transition. Do we have records on them, or are we retraining? Are we shutting down the office again and getting training? Are we, having them go online and hit up a learning management system to get training? That's going to be some key information right there. There exists a lot of potential landmines. Are there written safety programs available? Right. And that's kind of echoing what we've said throughout. Are they there? Are they updated? And, do they actually apply to your facility? Are they just something you picked up off Amazon and they've been sitting up in the cabinet for 2-3 years looking in that nice, pretty green and white binder? And have you ever had an inspection at this facility? And that information about an inspection could be a third party, like what the good folks at Smart Training do. Is it something that maybe an industrial hygienist came in? Is it something that maybe you had a trainer from a third party come in and do a mock inspection? Or have you had someone from the Department of Labor come in and do an inspection? Have you ever had an inspection at this facility? And what are the results? You want to see that. That should be disclosed. You need that information. That's crucial. And a couple of other questions that we want to keep in mind. And again, these are somewhat similar, yet slightly different. Has this facility ever been part of a data breach? That's one of those landmines that can bite you down the road if there aren't business associate agreements, which is the next one in place for anyone who handles PHI. And I would share some information too on those business associate agreements. That's kind of, it's important to know. There are some individuals, some entities that will not sign one. They will not sign one. So if you find yourself in a situation where you don't have BAAs because an organization, like it could be a dental lab, it might be, I actually just saw this morning from 3Shape Trios. If you do scanning, they have a cloud service apparently that they use to house some of that PHI, but they're European Union and they don't go by HIPAA. They're certainly not going to sign a business associate agreement. So I would be hesitant with, maybe storing PHI internationally. So something else to keep in mind there, of course. But do BAAs exist for those who share patient PHI? And do you have upset current or old employees out there? Like, do I have folks that are going to be, like I said earlier, breathing fire? Is there something I'm going to, come in tomorrow morning or in 6 months from now to a lawsuit or something? Like what's going on here? So that's yet more important information to, that I would strongly encourage buyers to ask a seller. And, if the practice has been inspected, there's a very good chance that all of these items hopefully have been resolved, and it's going to be a nice and smooth transaction. So lingering questions here going forward. How do we get on the right path and alleviate the concerns? We talked about that in spending time as a team and spending time kind of addressing the items, making assignments, and following up. That's key. There's no shortage of follow-up that needs to occur. And unfortunately, that oftentimes is what's missing the most is the follow-up. I am not a fan of picking on anyone, especially those who are trying to do the right thing. But a lot of times, an inspection report gets printed out, it gets accessed, it sits on the desk. We have the best intentions, and then life happens and it gets pushed off to the side. I mean, obviously, if we're in a transition, we're probably more focused now more than ever than we would have been. But that's something to bear in mind as far as alleviating concerns. And what else could potentially be lurking around the practice now that we've got our antenna up? We've looked at some of these major items. Did we look at like structural items? When was the last time you opened up the cabinet in the fifth operatory? Like things like that. Like what else could be a potential issue here in my practice that I'm just simply not aware of? So kind of keep those things in mind. What could be lurking around? And outstanding issues. Like, do we have a lot of patients that might be, wary about anything like upset maybe with treatment, or maybe there's been some issues in the past, or are those folks gonna crop up afterward? And maybe there's some proactivity we can do there. Just outstanding issues. Things happen, and it's important to have kind of a global view of that, and make sure that we're addressing any potential pitfalls that could exist out there that aren't on your report. And a lot of times that's where all the questions you might ask a person doing your inspection, or the questions you might ask someone who's advising you, use those tools. So many people don't take advantage of, like, I'm going to say, the experts around them. There are no silly questions. Just be a rascal, ask the questions. I can't encourage that strongly enough. This item here that I did want to share is our non-compliant, and I apologize, it's somewhat blurry, but our non-compliant inspection items, the last 12 months, these are the top 10 issues that we have found. I wonder how many this is. I think this is out of about 600 inspections, if I'm not mistaken. But these are the most common issues that we've bumped into. And Josh, how am I doing on time here? I'm wondering if I have time to really dive into these.
We've just got 2 or 3 minutes left, and then we got to wrap it up.
Okay. I want to cover just the first couple of these that maybe we didn't already go into in the inspection. So I will brevity is the soul of wit. One thing I wanted to add here is this top one is an issue that we bump into with, oh my goodness, almost everyone we inspect. Each chemical removed from an original container and placed into a secondary container is labeled. Oh my goodness. Please, when we're done this meeting, take a stroll through your treatment areas, your sterilization area. If you're using concentrates of any kind, like Cavicide, Optum 1, Biosurf, and you have them in their own little spray bottles in each operatory, or maybe you're saturating 4x4s or something to that effect, please put a secondary or GHS chemical label on all those individual bottles, and be on the lookout for anything else like that in the practice that may need labels. That's something so many people miss. It is considered a serious violation. For obvious reasons. Another item real quickly that I would mention with that, those little squeeze bottles of alcohol that are brown or clear that we, squeeze onto a 2x2, clean an instrument, a mirror, what have you, those need labels as well. Just them saying the word alcohol on the outside is not sufficient. It needs to have a secondary chemical label because there are associated hazards with it. So I would encourage y'all to look at that. And the other item on here that I really wanted to mention is, does your practice have a designated privacy officer? Do you have someone who's making sure everyone has the appropriate HIPAA training, is protecting PHI, is completing a risk assessment, is ensuring that you have business associate agreements with those entities that you share PHI with, and is all the proper paperwork in place and updated annually? Josh, I think those were my my two extra ones on there that I want to cover.
That's great. So if there's any last questions that anybody has, David, was there anything else that you were going to present?
I was going to leave this up here. It was 640 inspections. The average score was 80%, and we found over 11,000 items just in the last, 12 months from when I made this presentation. So good gravy. That's a lot.
Yeah. Absolutely. So thank you, David. Really appreciate all that you brought up here. Is there any last questions that anybody has? There's a couple of additional questions that I had thought of asking. Most notably is, how can lapses in HIPAA compliance arise during a praxis transition, and what can you do to safeguard to make sure things aren't happening while you're going through a transition?
Well, I think the most important thing is going to make sure that you have the training or your HIPAA training in general completed. And if you do have any kind of issues or any inkling that there's something going on, always repeat the training and then start going through a checklist. And that checklist is, do I have my BAAs created? Do I have those? Are they signed by both parties? Is there documentation? Do I have my notice of privacy practices on my website and available in hard copy in the practice? Those are three of the more common issues you're going to have, especially if you're in a transition. I would strongly encourage you to do a HIPAA risk assessment or redo your HIPAA risk assessment at that point. You can find those through obviously our LMS. We have a HIPAA risk assessment. I think you can find some real watered down versions elsewhere. But that's what I would encourage anyone to do at that point.
Okay, great. And David, I know you do a lot of work with new dentists in particular. How can new dental practice owners ensure continuity and compliance practices while still making improvements and changes to the overall practice? I know that there's usually 1,000 things that has to be done. How do they keep focus on compliance and making progress there while handling all the other business?
Yeah, you're going to want to have a champion in place. There's no other way around that. If you have a trusted clinical lead, or as a new practice, I oftentimes see docs that are like, I'm working late on Fridays. We finish with patients at noon. You know what, doc? Sorry, first year, second year is going to be tough, but you're going to want to spend a dedicated amount of time at the end of every week, verifying things have been documented, systems are in place, assigning champions to different roles, and holding accountability. Accountability is probably going to be your most important item there, is saying, if this is not getting done, there are repercussions. At the end of the day, I'm responsible for this. So it's going to be a time investment in assigned champions.
That's perfect. Thank you. Stitching time saves 9, right?
Amen.
Okay, thank you so much, David. So this completes the CE portion. I do want to just give Maria from Caber Hill just a moment. And let me give a brief introduction for her. As a leading merger and acquisition advisor in the dental industry, Maria's mission is to help both individual dentists and dental groups navigate the complex landscape at dental practice transactions. Maria has extensive knowledge of the dental industry and brings a wide breadth of skills to the table, particularly in valuation. She is an expert in helping clients understand what a dental practice or dental group is worth. She determines business evaluations based on tangibles like equipment, actual cash flow, and profitability. But she also understands that a more complete picture of a practice value includes much more, including variables like business climate, market demand, and competition. Dental-oriented and team-focused, Maria is a confident, effective negotiator with a strong track record of helping clients close transactions and achieve the best possible outcomes for all involved. With that, Maria, let me turn the time over for you for just a minute.
Thanks, Joshua, and thanks, David. I think this is a really important conversation and something that is often overlooked in the transaction world, especially for first-time buyers. I think it's really important to take a look at non-financial things, which I think is often a big focus, especially for first-time buyers. And so having this framework and having this conversation is really important. I think what's also important is that there are a lot more sophisticated buyers in the marketplace today that absolutely are looking at things like OSHA and HIPAA compliance as part of their due diligence efforts and processes. And maybe even more importantly, I think looking into these systems and processes at practices or smaller groups also is a sign as to the culture of those organizations. And, when you're thinking about acquisitions, understanding culture is really important, because that's going to impact, the integration of those practices into the larger group, and could actually signify situations that you might not want to actually bring into your group, or you might not want to take over if you see that there's a strong cultural clash. And the last thing I'll say as it relates to the more sophisticated buyers in the marketplace, they also take a longer look at compliance, and typically are asking for a 3 to 5 year look back. So being on top of compliance programs, not only ensuring that you're up to date and current, as David has pointed out in many instances, but also ensuring that you're not, having items that need to be reported in other areas of due diligence, say, malpractice claims and things of that nature. So very important topic. So glad to be with you guys today, and thanks for having me.
Thank you, Maria. I really appreciate it. Thank you, everybody, for joining us today. The best time to plant a tree is 20 years ago. The second best time is today. Same goes with compliance, as well as the other facets of preparing for a practice transition. If you're thinking of selling or buying, I encourage you to reach out to Maria. If you had any questions that you wanted to go further in depth on anything covered by David, please reach out to him or myself or anybody on our team. We're here to help you. We love the dental space. There's so much good work going on, but as Maria said, there's an elevation that is beginning to be expected in a dental place. It's no longer okay to do the same thing that was done 30 years ago. People are demanding you to stand out, and there's many different ways that your practice can stand out. So with that, thank you again. We will send out a link to the recording here briefly, and then expect a certificate for the CE in the next day or two. And with that, y'all have a great day.